Welcome to the Windsor Regional Vascular Health and Research Institute's comprehensive head-to-toe blueprint supporting the research and clinical care of high-risk vascular patients. We will guide you through our institute's academic model of care. The cerebral component of the model is the vision and rationale for our approach, which outlines the need for systematic healthcare reform. With the arms of the model, we are reaching for better patient outcomes and reduced costs within our healthcare system. The heart and soul of our institute's philosophy is a novel 5-pillar model of care based on academics and research. This philosophy circulates throughout our entire organization and is embodied in the goals of our model. We've established a solid foundation rooted in past accomplishments, current strategic vision, and future objectives. Windsor and Essex County has one of the highest rates of cardiovascular and kidney disease in the province. The Windsor Regional Vascular Health and Research Institute is a university-affiliated, academic and research-focused organization hoping to serve the high-risk cardiovascular and kidney patient by effectively optimizing specialty care services through an evidence-based and integrated 5-pillar model of care. Our primary goal is to utilize an academic and research-based approach to reducing morbidity and mortality from cardiovascular and kidney disease, with the support and involvement of all local specialists coordinating care plans with primary care practitioners and prospectively evaluating patient outcomes. Vascular or cardiovascular disease affects virtually every organ across numerous medical specialties, encompassing any disease that involves the blood vessels. Thus, many chronic conditions fall within this category, including coronary artery disease, cerebrovascular disease, peripheral arterial disease, and chronic kidney disease. All of these conditions have very similar risk factors such as diabetes, hypertension, dyslipidemia, established atherosclerotic disease, obesity, and smoking. Since they all have virtually identical risk factors, they often coexist together. Therefore, it is our position that the full spectrum of vascular disease should include heart disease, stroke, peripheral vascular disease, and kidney disease as a single system of disorders. The vast majority of chronic kidney disease, or CKD, cases are due to diabetes, hypertension, and vascular disease. In the high-risk CKD patients, statistics show that approximately 80% of kidney patients will die of cardiovascular disease, often before they ever need dialysis. The number of patients on dialysis within the last 15 years has roughly quadrupled in Windsor and Essex County, while the population has been relatively stable. Between 2007 and 2011, circulatory diseases accounted for a mortality rate of 33.2% in Windsor and Essex County. These local statistics are alarming. A significant proportion of our community are at risk of experiencing vascular disease or related complications. There is an ever-increasing urgency to better serve this at-risk population. Changes are needed within our healthcare system to better serve the high-risk cardiovascular and kidney disease patient. Our population demographics are changing. We have an increasingly aging population. Between 1956 and 2011, our elderly population has increased over 700%. As our population ages, the risk of significant illness increases, and consequently, so does the expense of healthcare. The cost of healthcare spending on a senior over the age of 80 is 400% higher than someone between the ages of 1 and 64. In addition, risk factors for cardiovascular disease such as diabetes and hypertension increase with age, and correspondingly, mortality from circulatory diseases with age increases dramatically as well. In 2006, the mortality rate from cardiovascular disease for seniors over 80 was 38%, 350% higher than people aged 20 to 44. An escalating proportion of patients have multiple coexisting chronic conditions, which can significantly elevate their risk of cardiovascular disease. The high prevalence rates for hypertension, diabetes, high cholesterol levels, obesity, and kidney disease as we age result in a significant portion of the population managing many, if not all, of these conditions simultaneously. Comorbidity is a significant problem as it leads to more complex clinical management, which can be extremely challenging when many different specialists are involved without the tools needed to effectively coordinate and optimize patient care. A system which does not optimize the coordination of these valued healthcare specialists may lead to adverse patient outcomes and increased consequences to patients and to the healthcare system. A patient with chronic kidney disease, or CKD, may have to manage diabetes, hypertension, cardiovascular disease, cerebrovascular disease, coronary artery disease, and peripheral vascular disease, all at the same time. Managing multiple chronic illnesses, numerous prescriptions, and at times conflicting approaches to management can be immensely challenging and confusing to patients seeing several healthcare specialists in isolation. For instance, being able to balance the conflicting dietary restrictions between a diabetic and renal diet can be quite onerous to patients. Conflicting fluid intake recommendations for patients managing both kidney and cardiac disease can be confusing. Making the most optimal medication choices, knowing when to dose adjust certain medications, managing contraindications and side effects in patients that are on multiple different medications with different indications can be difficult to juggle. For example, in the most high-risk diabetic patients with hypertension, 3 to 4 medications are often required just to manage their blood pressure, not to mention all of their other conditions. Traditionally, our healthcare system is siloed and tends to focus on disease or condition-specific interventions, often in isolation of the efforts of other healthcare practitioners with very little real-time communication. This can inadvertently lead to adverse outcomes due to suboptimal coordination and timeliness of care. For instance, in most pre-dialysis clinics, the focus for advanced chronic kidney disease is often on managing and limiting renal-related complications such as anemia, altered bone metabolism, fluid balance issues, as well as dialysis preparation and modality selection. What may at times get lost in the process is that optimally managing cardiovascular risk factors is of even greater importance in reducing morbidity and mortality to CKD patients. The high-risk vascular patient journey often involves seeing 3 or 4 different specialists such as an endocrinologist, a cardiologist, a nephrologist, a vascular specialist, a neurologist, and/or an internist, etc., on a regular basis while still trying to maintain routine contact with a primary care practitioner. In fact, an advanced chronic kidney disease patient is recommended to see their nephrologist up to 6 times per year. Multiple medical visits to different specialists, numerous different laboratory investigations attached to each of these visits, additional investigations and imaging tests, often with significant duplication, may translate into well over 20 different medical visits per year. And this does not consider any other medical conditions a patient may be trying to manage as well. This can be quite time-consuming and overwhelming to patients and family members who often have to take time away from work and home to attend these appointments. This can lead to medical visit fatigue and subsequently a lack of attendance. The burdens of a siloed and reactive healthcare system include increased acute complications and ER visits, increased wait times, inaccessible files, discontinued preventative therapies, polypharmacy, and duplicate investigations. All of these burdens increase the cost and consequences to the healthcare system as well as to the patient. To a patient with multiple chronic illnesses, navigating through our current healthcare system can be quite onerous. If patient care is not optimally coordinated or attended, there is a potential for detrimental patient outcomes. Patients overwhelmed by multiple medical appointments often experience medical visit fatigue and may not consistently attend scheduled appointments, which can lead to adverse patient outcomes. Improving attendance to medical visits in both primary care and specialty care settings would lead to improved preventative care maintenance and better overall patient health. Patient adherence to proven therapies has been shown to be as low as 50%. Improving adherence can lead to better patient outcomes such as the reduced incidence of disease, disease progression, morbidity, and mortality. Data suggests that optimizing proven therapies can reduce the high-risk cardiovascular population from 20% down to less than 5%. This can have a dramatic effect on reducing the incidence of cardiovascular and kidney disease, with less people having heart attacks, heart failure, strokes, and kidney failure. This will reduce overall patient morbidity and mortality, as well as reducing healthcare costs. An improved coordinated collaborative system would certainly improve patient outcomes by improving clinical management. Integrated global patient care maps created by a collaborative multi-specialty care team would lead to improved clinical outcomes. This can optimize the role of the primary care practitioner in carrying out comprehensive care plans designed for the high-risk patient. Access to care is a significant factor in patient outcomes. In particular, in subacute situations, when specialty care is not readily accessible, this may lead to increased emergency room visits and potential hospital admissions. In our current system, access to semi-urgent specialty care is usually through the emergency room. Enhanced access for subacute care can prevent progressive clinical deterioration, and by using a community-based specialty center with enhanced specialist access, patient outcomes can be improved and we can reduce acute care costs. The leading cause of hospital-based healthcare expenditure in Canada is the treatment of acute cardiovascular disease. In 1998, cardiovascular disease was responsible for over $21.2 billion in expenditures. From 2004 to 2005, acute care inpatient costs for diseases of the circulatory system cost over $3.29 billion. the most expensive clinical healthcare sector. In Canada, the public sector carries roughly 70% of the costs of healthcare. Thus, expenditures become the burden of taxpayers within our healthcare system. The rising cost of delivering service in an acute care setting is putting a strain on our healthcare system. Finding ways to keep our population healthier and avoiding emergency room visits and hospitalizations not only benefits patients and their families, but also all of those responsible for maintaining our healthcare system. It is extremely important to build the appropriate capacity and services within the community to prevent acute illness and the progression of chronic disease, to limit vital organ damage and the need for emergency room visits, hospital admissions, and acute care services. High-risk patients incur both direct and indirect costs from the current siloed model. The reduction in quality of life to patients, stress on families, and the economic impact of lost wages are significant side effects and deserve implementation of quality improvement measures. Examples of direct costs to the healthcare system include emergency room visits and hospitalizations, but there are also indirect costs to patients such as traveling expenses and lost wages. The cost of delivering certain services in community-based models has been shown by the Ministry of Health to be less costly than in hospital settings. In fact, studies show the cost is approximately 30% lower. Implementing community-based models of care where appropriate can translate into significant savings to the healthcare system. The potential savings associated with implementing more cost-effective healthcare strategies can be reinvested in supporting our frontline healthcare professionals with better staffing, resources, and technology to make available the highest quality acute care services when needed. By examining all of these statistics, it becomes indisputable that decreasing the healthcare burdens of chronic disease would be a tremendous benefit to the entire populace. The high-risk cardiovascular and chronic kidney disease patient would be ideally served in a single-site, multi-specialty, and multidisciplinary Vascular Health and Research Institute with a common electronic medical record, or EMR, and enhanced coordination of care between specialists and primary care practitioners. The target patient population would consist of those that already require ongoing input and collaboration between multiple specialists and primary care practitioners to improve health, avoid emergency room visits, and the need for acute care services and hospital admissions. This includes patients with established cardiovascular disease, advanced chronic kidney disease, cerebrovascular disease, peripheral vascular disease or wound care needs, difficult to control risk factors such as hypertension, diabetes, or dyslipidemia, significant complications of therapy or significant polypharmacy, or those at high risk of requiring subacute or emergency services or hospital admission. The Windsor Regional Vascular Health and Research Institute plans to prospectively research a novel 5-pillar model of care. The first pillar is patient-centered and accessible care. Models of healthcare delivery must become more patient-centered in order to be successful in achieving desired outcomes. We must realize that the challenges that patients face are real and meaningful, and unless addressed, can limit our ability to deliver cost-effective care. Simple measures such as increased hours of operation of a clinic and free parking can dramatically improve attendance and ensure that fewer patients are lost to follow-up. Once a patient is lost to follow-up, they would be more likely to experience disease progression and require the use of emergency services. Reducing the total burden of visits for care, i.e. less lab work and testing duplication and multi-service visits, while enhancing interaction with specialty services and primary care practitioners will likely lead to a greater adherence to therapies and attendance to visits. In addition to expanded hours, the availability of subacute care and reduced wait times to see specialists can reduce the need for emergency room visits and hospital admissions by addressing issues proactively to prevent acute illness from developing. Using technology such as video conferencing to reduce travel time for patients can also be incorporated to improve access to care. Having multi-specialty such as cardiology, nephrology, endocrinology, neurology, internal medicine, vascular care, and wound care, as well as multidisciplinary services such as nurse practitioners, physician assistants, social workers, dietitians, and clinical pharmacy specialists, as well as lab technicians, coordinated at a single-site community-based center, will ensure that patients who need services will have ease of access. Comprehensive and coordinated patient care that is easier and more accessible to patients, as well as continuous follow-up and reinforcement with primary care practitioners, will almost certainly enhance patient satisfaction, which usually translates into greater uptake of proven preventative therapies and improved patient outcomes. The second pillar is prevention and wellness-focused care. As a healthcare system, we must shift our focus and resources from treating established acute illness to promoting health, wellness, and disease prevention. This will not only help keep our population healthier and living longer with a higher quality of life, but will also reduce acute care expenditures that account for a significant proportion of overall healthcare costs. Increasing education among affected populations in conjunction with enhancing public awareness is a key component of promoting health and wellness strategies. Using available technology and web-based approaches for education and awareness will help patients and family members engage more actively in their care. Promoting self-management strategies has been shown to improve achievement of key target quality indicators. Early primary and secondary intervention strategies have been proven through numerous clinical trials to be more effective than late interventions in chronic disease management. The overwhelming evidence on preventative health management definitely illustrates its importance in improving patient outcomes. The third pillar is enhanced coordination of care for patients. Using a comprehensive coordinated team approach to the care of the high-risk patient will have many quantifiable benefits to patients and to the healthcare system. Enhancing coordination of care has the potential to dramatically improve uptake of proven preventative therapies and reduce the incidence of cardiovascular and kidney disease. Too often, due to the lack of coordination of care and information sharing, important proven preventative therapies for cardiovascular and kidney disease are discontinued and never restarted or never initiated in the first place. Studies show that the uptake of these proven therapies may be as low as 50%. The use of a single electronic medical record, or EMR, with a database with 24-hour access can help various healthcare team members easily access information that is vital in preventing errors and ensuring that each patient has the most optimal care plan. Improving this uptake can have a dramatic effect on reducing acute illness and organ damage that can increase patient morbidity and mortality. In addition to this, enhanced coordination of care can reduce polypharmacy and potential medication errors that can lead to adverse events and emergency room admissions. Case managers, such as nursing specialists and clinical pharmacy specialists within the specialty team, will provide comprehensive care plans and continuous updates to primary care practitioners and the patient's existing pharmacy, who are vital in reinforcing treatment strategies that will enhance patient adherence and improve outcomes. On an outpatient basis, in our traditionally siloed system, there are often significant wait times to see specialists. This leaves opportunities for patients to fall through the cracks when subacute management issues arise. In a coordinated model, where multi-specialty assessment is immediately available when necessary, there will almost certainly be higher success rates in avoiding rapid clinical deterioration, which prompts the use of emergency room services for access to urgent specialty care. Overall, multiple specialists and healthcare team members interacting around complex cases in a coordinated fashion can only improve quality of care and patient outcomes. Greater access to specialty allied healthcare professionals such as dietitians, social workers, etc., will allow for even more optimal and comprehensive care. The fourth pillar of care is a strong focus on academic and research-oriented care. A high-functioning team of healthcare specialists is likely to accomplish more than any single individual could in improving patient outcomes. Opportunities to collaborate, information share, and transfer knowledge and practice patterns in an academic research setting can only lead to benefits for our patients. Promoting research in a teaching environment in a community-based setting would be an exciting and intellectually stimulating opportunity for aspiring physicians and healthcare personnel that would ultimately enhance recruitment of elite professionals. The use of a single database will enhance research opportunities in cardiovascular and kidney disease management. This will provide the opportunity to prospectively study the short and long-term benefits of this model in reducing rates of cardiovascular and kidney disease-related morbidity and mortality in our region. The opportunity to provide regular teaching and educational lectures to medical and nursing trainees within the community about chronic disease prevention will enhance the experience of the younger generations of healthcare professionals. Hopefully, this will help to shift traditional models of healthcare education, which have historically focused on treating acute illness, to a model more focused on promoting wellness and disease prevention. The fifth and final pillar is cost effectiveness with quality assurance, which is important in the implementation and sustainability of any novel model of care. Any novel model of healthcare delivery must focus on improving the quality of patient care while maintaining or reducing costs to the overall healthcare system. A single-site, community-based coordinated specialty center for cardiovascular and kidney care has the potential to be a more cost-effective solution than traditional models of care. Enhanced coordination and access to specialty care will likely lead to less duplication, increased patient attendance, increased adherence to therapies, reduced emergency room use, and hospitalizations. Over time, this may translate into significantly reduced kidney failure requiring dialysis, coronary artery disease, peripheral vascular disease, congestive heart failure, and stroke rates. If this indeed is the case, it would translate into tremendous savings to our healthcare system. Improving quality targets by only 5% can translate into hundreds of millions of dollars in savings. In addition, currently for hospitalized patients with multiple chronic illnesses, they are often kept in hospital longer than needed solely because of a lack of coordinated multi-specialty care within the community to allow for a safe discharge. This type of clinic has the potential to reduce length of stay of an admitted hospital patient with multiple chronic issues that needs close comprehensive attention post-discharge in a timely fashion. This type of model also aligns closely with funding agency reforms and the stated direction of promoting community-based care in a patient-centered fashion. A clinical advisory board with a quality assurance committee will oversee the model with representatives from patients, primary care practitioners, specialty care, allied health professionals, funding and academic agencies to ensure the needs of patients, healthcare providers, students, and government agencies are being met to a high level of satisfaction. This will help continually improve patient outcomes and ensure the implementation of continuous quality assurance measures. The five-pillar model of care hopes to achieve the following: enhance patient satisfaction, increase patient safety, increased attendance to healthcare visits both in specialty and primary care settings, enhance use of multi-specialty algorithms and care maps aimed at cardiovascular and kidney disease therapy adherence, enhance uptake of preventative therapies proven to reduce cardiovascular and kidney disease, increase satisfaction of primary care practitioners with specialty services, enhanced wellness promotion and adoption of self-management strategies and home-based therapies, reduced emergency room visits, reduced length of stay in hospital, a reduction in crash starts onto dialysis, a reduction in the incidence of end-stage kidney failure requiring dialysis, a reduction in costs related to acute care management of cardiovascular and kidney disease, a reduction in cardiovascular events such as myocardial infarction, stroke, need for amputations, heart failure, and death rates from cardiovascular and kidney disease, increased academic activity with enhanced research opportunities, enhanced quality coordination of outpatient medical and nursing teaching programs. This model of care aligns with the principles of our provincial Ministry of Health and Long-Term Care objectives for chronic disease management. We have been fortunate to receive support from local and provincial healthcare agencies. A letter of support for our vision was provided by the Erie St. Clair Local Health Integration Network, stating the shared vision for improvement of chronic disease management and prevention in our local community. The Ontario Renal Network has also provided a letter of support that shows the vision alignment with the ORN's strategic priorities to reduce the impact of chronic kidney disease by improving detection and prevention of progression. In addition, the Cardiac Care Network, Heart and Stroke Foundation, and Ontario Stroke Network collaborated in August 2012 to produce an integrated vascular blueprint for Ontario. They reached similar conclusions about the benefits of an improved, patient-centered, and integrated system to improve services, continuity through transitions, health outcomes, and quality of life for patients and caregivers. Healthcare agencies, providers, and patients recognize that change is indeed necessary to achieve the ultimate goal of improving patient care in a cost-effective manner. In order to meet the needs of an aging population from a cardiovascular and kidney perspective, we need to limit the escalating costs of providing acute care services that are not likely to be sustainable without fundamental healthcare system reform. If we do nothing, not only are we accepting suboptimal patient outcomes, but in the absence of increased public taxation, this may translate into a reduction in services to patients, resources to frontline healthcare workers, and funding to acute care facilities. Traditional models of care must adapt to our changing population and their healthcare needs while demonstrating cost-effectiveness and long-term sustainability. Embracing the philosophical need for change is understandable to the vast majority who work within our healthcare system. Nonetheless, changing existing healthcare systems and traditional practices is not an easy task. It requires buy-in from key stakeholders, including funding agencies, healthcare providers, as well as patients as end users. Any proposed systematic changes must incorporate the following 5 key principles to enhance adoption. 1. It must have a patient-centered focus. 2. There must be evidence-based decision-making. 3. There must be a high likelihood of improved cost-effectiveness. 4. There must be measurable outcomes of value to patients, providers, and healthcare agencies. And 5, there must be minimal disruption to existing practices. It is important to remember that making only small incremental improvements in key outcome measures can have dramatic effects on the healthcare system in decreasing morbidity and mortality rates, as well as significantly reducing healthcare costs. So the real question becomes not whether we are doing a good job currently, but rather whether or not we can do better. All key stakeholders in the healthcare field inherently want to see better outcomes for patients within our healthcare system, but often just require the right vehicles to arrive at the desired destination. We are extremely excited about the opportunities that can arise from increased collaboration of local specialists in a teaching and academic environment, stimulating innovative ideas and fostering research. A community-based research institute in cardiovascular and kidney health will provide an incredible opportunity for improving vascular care for our region. A research and academic-based institute will focus on chronic disease prevention management and ultimately help to reduce morbidity and mortality. Patient-centered strategies supported by evidence and provided by collaborative healthcare teams will work to effectively optimize complex care plans provided to primary care practitioners for the high-risk patient. Supporting cardiovascular and kidney care specialists within the facility and armed with the resources they need to effectively intervene in a timely, coordinated fashion will undoubtedly reduce the risk of emergency room utilization, hospital admissions, and the need for acute care interventions. A team of specialists with comprehensive support services working in an academic environment and in collaboration with primary care practitioners can only help enhance care delivered, which is ultimately the main goal for all key stakeholders in our healthcare system. There are 3 primary goals of the Vascular Health and Research Institute. The first goal is to better support the central role of primary care practitioners who have the greatest influence on affecting positive healthcare changes in patients in order to reduce the incidence of cardiovascular and kidney disease. The second goal is to improve coordination and access to specialty services in order to better meet the needs of patients and primary care practitioners. The third goal is to incorporate research and continuous quality assurance measures with the goal to improve healthcare outcomes and cost effectiveness. These goals represent the vision for vascular health integration in order to provide optimal patient care and outcomes in our community. Research is an essential element within the field of medicine and in analyzing healthcare systems, which allows for continuous quality improvement. Our research group has been progressively implementing components of this model since 2011. We have established Canada's first American Society of Hypertension accredited specialty hypertension clinic. We have coordinated a multidisciplinary community-based team. We've established a community-based chronic kidney disease clinic. We have secured a centrally located community-based site. We have developed a university-affiliated academic and productive research team. Our research team has been awarded a prestigious grant to conduct the first ever randomized controlled trial based in Windsor. We have implemented a single electronic medical record. We have established a local nonprofit charitable foundation, the Care for Kidneys Foundation. We have developed patient education resources for distribution within the community. We have engaged local and provincial funding agencies and obtained letters of support from their organizations. Despite our best efforts as a healthcare community to date, the rates of cardiovascular and kidney disease in Windsor and Essex County are among the highest in the province. Let's work together to do something more about it. For more information and to support our cause, please visit our website at www.careforkidneys.org.